Very good evening to all the speakers, chairpersons, moderators, panelists, and to our own IFS Secretary General, Dr. Shweta, and President Sir, Dr. Pankaj Talwar Sir. And good evening to the to all the August audience. As we all know that today's webinar deals with the let me introduce myself. I am Dr. Pratistha Dalmia. I am Director of Dalmia Infertility and Test Tube Baby Center, Gwalior. I am the master of the ceremony. I'm also an executive of IFS MP chapter since 2022. So I'm just the master of the ceremony of this webinar. So with the permission of all, I'll start this. As we all know, our today's webinar deals with the intricacies of PCOS and IVF. Our main focus will be on the practical aspects we encountered in our day-to-day life practice when we do an IVF in a PCOS patient. Stimulating a PCOS patient for IVF can be a roller coaster ride which encounters sometimes no response or hyper response to the extent of hyperstimulation, production of large number of follicles, poor quality of oocytes leading to lower implantation and cleavage rates, and also higher miscarriages rates. I hope we all benefit from this webinar. Now, I don't know whether Dr. Priya Bhave has joined or not. I want to invite her for her welcoming address. Next slide. Hello. Hello. I think Dr. Priya has not joined. I'll continue with the welcoming of all the guests, the President, Dr. Pankaj Talwar Sir, and Secretary General, Dr. Shweta Mittal. Dr. Priya is at present the Secretary of IFS MP chapter. We all know her. She's a true leader under whose leadership MP chapter has grown and received several awards since last few years. She is a true visionary and a motivation for all of us. Now I invite Dr. Neeti Tiwari for her brief introduction to the webinar. Dr. Neeti Tiwari, ma'am, please. She is a senior consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. And she is also an executive member of IFS 2022-24. She is a convener of IFS SIG PCOS. Dr. Neeti Tiwari, ma'am, please.
And thank you so much for the kind introduction. Today we are here with our series of webinars which we are doing from SIG PCOS, and I thank Dr. Priya Bhave and the MP chapter for giving this opportunity to collaborate with them. So we have done webinars on specific topics in PCOS. So we started with adolescent PCOS, then we did one on the ovulation induction IUI, and this is the third webinar which is on the IVF in PCOS. So a very interesting webinar where we will have different topics which will be taken by experts like Dr. Basair ma'am, and then there will be a panel discussion where we will be discussing the challenging situations encountered when a patient of PCOS is taken up for IVF. And I thank Dr. Shweta Mittal Gupta for joining us today. She's the Secretary General, very busy person, and it is an honor that she's here with us today. So, Dr. Shweta, could you just say a few words here?
So, good evening, everyone. Dr. Neeti, thanks so much. She's a dear colleague. We are like sisters in the department. So, very active, I would say, SIG, PCOS with super active MP chapter. So, thanks, Dr. Neeti, and thank you, Dr. Priya, for collaborating, joining hands. And I'm sure this is going to be a wonderful, webinar. PCOS, though it's so commonly dealt in, lesser patients with PCO profile will land up in IVF, but the challenges still remain even when they enter IVF, because we know sometimes it's not just being a hyper response, but sometimes they are such tricky responders. It becomes very difficult to stimulate them. get the right response, what we want, then looking at the right maturity and looking at that they form the right embryo. So it becomes a big task. So the topics, what I could see with such experienced faculty today, I think it's going to benefit all the listeners, where they're going to tackle with, IVF and what are the challenges in PCOS women specific to them. Then how can we achieve an OHSS free clinic? Because yesterday itself in 2025, I get a patient whose only scare was that my last IVF cycle, I had severe OHSS and I had to be hospitalized and I need a second IVF, and I've come to you only with one condition, that no matter what, I should not land up in ovarian hyperstimulation. So this is the kind of scare what patients have once they are hospitalized in 2025, when we are so looking at or learning how to be an OHSS free clinic, I think is very important. And then a panel on different case scenarios. I'm sure there will be such interesting cases because no single PCO behaves the same. So I congratulate both the teams and I wish all the best. And I'm looking forward to a great webinar.
Thank you, Dr. Shweta. Thank you for the kind words. And before we begin with the webinar, I would request all the delegates who are present here, who, however number we have, let's make it a very interactive session. Let's talk about our experiences, the patients we have encountered. So besides the faculty which is there, the panelists and the moderators and the speakers, the delegates can put their questions in the chat box, and we will take up those questions in between. Let's learn from each other's experience. I'm sure whoever has joined here, they all are very experienced clinicians, so let's learn from each other's experience. Thank you so much, and over to Dr. Pratishtha.
Thank you, Dr. Neeti. So we'll start with our first session. The chairpersons for the session are Dr. Rosa Oliai ma'am and Dr. Rosa Oliai ma'am and Dr. Aradhna Gupta. Rosa Oliai ma'am, as we all know, is a director of Oliai Hospital, Gwalior, and she is also a state coordinator for Foxy Aduna and national representative member of Medical Advisory Panel, Family Planning Association of India, and she is at present the president of Gwalior Obstetric and Gynecology Society, and she was also the vice president Foxy in 2014, and she was awarded the prestigious Dr. DC Datta Prize and also prestigious Mehru Dara Hansotia Prize. So welcome, Dr. Rosa ma'am. Dr. Aradhna Gupta, she is a director of the Aradhna Test Tube Baby Center, Bhopal, and the member of the State Appropriate Authority Committee, ART and Surrogacy. She is also managing committee member, MP Isar. She has a 29 years of vast experience of her practice in reproductive field. So these are our chairpersons, and our first talk is by none other than Dr. Archana Baser ma'am, and we all know her. She's a very respected and reputed in MP because of her. She's one of the pioneer of IVF in MP. So welcome, ma'am, and over to you for your talk, ma'am.
Hi, good evening, everyone. Can I be allowed to share my slide, please?
Yeah, sure, ma'am, sure.
Hello.
Is it seen?
This it's seen, Archana. It's seen. It's absolutely clear.
Okay, 1 second.
So meanwhile, let me congratulate Pratishta that she's coordinating and doing such good work. And doing this at the national level is really very important. And Gwalior is proud of you.
You are muted, Dr. Pratishtha. You're muted.
So it's not showing. You are sharing screen, yeah.
share the screen. No?
It's nice to see Niti also after a very long time.
Yes, ma'am.
In fact, one of my patients from Gangaram got conceived and came back to me, an IVF patient.
Oh,
So,
really?
Sarah, you'll have to
जी
do.
इसको इसमें करना है ना.
Ah, you are sharing your screen, so
Rosa, I
See your
just really
screen, but ma'am, make it full screen if possible. If
I
you
can see your screen, Archana. You have to make it full screen.
Yeah, but
It's
this
very
is
clear.
yeah, play from start. Yeah. Yeah. Can you see the full screen now?
Yes.
Hello.
Yes,
Yeah.
yes.
Okay.
It's better now. Yeah, go ahead, Archana. Go ahead.
Thank you, Dr. Priya, for inviting me. Thank you, Dr. Pratishta, for communicating me, Dr. Neeti,
Most welcome, ma'am.
and Dr. Talwar, and Dr. Mittal, and my dear friend, Dr. Rosa, for for chairing the session. I think it's very nice to see all friends here on the platform, and we are today talking about PCO, and PCO. So I am going to be taking challenges of IVF with PCO, and I know the PCOS still remains an enigma, and we all get baffled by the PCOS. So the next PCO is a widespread syndrome that poses unique challenges and constraints to the field of assisted reproductive technology. We know it is the most common cause of anovulation among infertile couple. Let's talk about IVF with PCO. Polycystic ovarian syndrome is the most common cause of anovulation, affecting up to 80% of women with this condition who present for IVF. Though actual incidence of PCO in reproductive age group is 9 to 18%, depending on the diagnosis, which is based on clinical or biochemical assessment of hyperandrogenism, combined with ultrasound assessment for polycystic appearing ovaries and or oligomenorrhea, is outlined by Rotterdam criteria. When a woman is undergoing IVF with PCO, firstly, what you have to do, all patients' pre-existing medical issues should be addressed prior to IVF to achieve the best and safest outcome. As we know that women with PCO have a lot of metabolic disorders with them. So we need to really take a good detailed history and assess their medical situation. Secondly, one must assess how to achieve ovarian stimulation and triggering to maximize oocyte yield while minimizing the risk of ovarian hyperstimulation syndrome. I think you have a full talk and a panel on OHS's free clinic. Thirdly, is the need to address how to best prepare the endometrium for implantation and pregnancy and mitigate pregnancy risk that may be encountered in this at-risk population. And in my talk, we will address each of these important considerations. So, what are the challenges faced in IVF with PCOS? Usually, we are worried about hyper response like OHSS. I am equally worried about hypo response and slow response. There you may get poor egg quality and empty follicle syndrome. There is always a risk of multiple pregnancy and pregnancy complications like miscarriage, gestational diabetes, and etc. So what are the pre-IVF preparations you will be doing in a patient who is going for IVF? First and most important is lifestyle modification, cycle priming, and various adjuvants, that is supplements and medications. So all patients' pre-existing medical issues should be addressed. Elevated age-specific AMH levels, decreased vitamin D levels, and elevated BMI, that is more than 30. It provides insight into choosing metformin pretreatment or our vitamin D supplements. And during IVF, choosing the optimal method of ovarian stimulation and triggering method are essential in lowering chances of OHSS and maximizing the egg yield. Metabolic syndrome is a constellation of physical and metabolic abnormalities which involve signs of insulin resistance. You have seen PCO with excess weight, hypertension, hyperlipidemia. Approximately 35% of PCO patients will have some form of insulin resistance, and 10% will meet criteria of diabetes mellitus. So, what are the interventions which you should be doing? You should, what we do, what everyone must be doing, that ask the women who is coming for infertility treatment and she has PCO that please reduce 5 to 10% of weight and they can lead to resumption of normal ovulation. And weight, if it is higher, it can also impact fertilization outcomes, with PCO patients having a 69% lower pregnancy rate per cycle at the start and a 71% lower live birth rate compared to lean PCO patient. Physical activity has also been shown to be beneficial in a pooled analysis, so they should do a diet and other methods of weight reduction, but physical activity is the most important thing. Now, many of women who are coming for IVF and they have PCO, what we see that they don't get their spontaneous periods, or some get very delayed cycles. So once a patient lifestyle has been optimized as far as the weight loss and physical activity, the question then arises how really to best prepare for actual IVF cycle. Whether you should be using only progesterone, or you should be using estrogen, or give a pre-treatment with combined oral contraceptive pills to synchronize the follicles in one common approach and get a withdrawal bleed. Now, what are the adjuvants which you should, which are being used in PCO? One is a myoinositol, melatonin, metformin, and if the vitamin D levels are low, they are being linked with abnormal metabolic outcome in PCOS patients. So these are the adjuvants which are being found to be useful in women with PCO, especially undergoing IVF, because they will reduce the doses of gonadotropin and they'll improve the outcome of IVF in PCOS. So these are the certain studies where they had a cohort of 2017 indicated that women with PCOS who started IVF following a spontaneous menses had a higher pregnancy rate and live birth rate compared to those that were on COC prior to their IVF cycle. So this is I came up with a very good study from our own Dr. Neena Malhotra on myoinositol versus metformin pre-treatment in GnRH antagonist cycle for women with PCOS undergoing IVF. And this is another reference for comprehensive review of therapeutic strategies for successful outcome. Now, what makes us wonder that what is the reason for anovulation in PCOS? So, women with PCOS are noted to have higher serum AMH level, with granulosa cell having up to 75-fold increased production of AMH. And what happens with the higher AMH level, there is a negative regulatory effect on FSH, which signals the inhibition of follicle development caused by AMH. So the elevated AMH is one mechanism which precludes cyclical follicular development in women with PCOS. So there are other metabolic aberrations also, like elevated LH levels, and this all leads to anovulation or hypoovulation in women with PCOS. So I'm just going to talk a very little about the hyper responders, because there is a talk on OHSS. I will be focusing more on hypo responders. So who are the women at hyper response in PCO? Age less than 35 years, polycystic ovary, low body mass index. There are lean PCOS are at more risk of hyper response. And if there is an enteral follicle count more than 24, and increased anti-Mullerian hormone levels, no exact cutoff, but generally more than 6 times of age match controls, they are at high risk of hyper response. And elevated serum estradiol level like 2500 to 4000 picogram per ml. Now, what are the stimulation methods? Once an IVF cycle is planned, the actual impact on outcome. The question is whether a standard you should use a long GnRH agonist protocol versus a GnRH antagonist protocol. And there are several studies, and now there are several randomized control trials which are suggesting that GnRH antagonist protocols seem to offer the best combination of cycle flexibility and OHSS risk minimization for PCO patient. So in our practice, we have totally shifted to antagonist protocol in women with PCOS because of is again that it gives a lesser chance of OHSS with antagonist protocol. Now, what kind of gonadotropins you should be using in PCO IVF, it entirely depends on what is your protocol and what you are comfortable with and what is your experience. It is like no two patients are similar, no two IVF centers will have a similar kind of protocols. So, I mean, you can use pure HMG, or you can use HMG also, you can use recombinants, or you can use only the FSH as well. And the dose, again, you can either use the soft ovarian stimulation protocol, that is start with the low dose, 75 international unit to 225 international unit. So it's entirely how you have you monitor your patients and your case selection, that is going to decide what protocol is best for you. There are nowadays talk about progesterone prime protocols also. There was a prospective cohort study by Zio et al., which compared a progesterone suppression, that is termed progesterone prime protocol, compared to a flexible GnRH antagonist approach, and found that progestin prime patient had similar pregnancy rate and lower AHSS rate, but the dose and duration of gonadotropin was greater in women in whom the progesterone prime protocol was used. There are minimal stimulation protocols as well. Minimal stimulation IVF has also been studied in PCOS population, and this protocol is meant to grow a cohort of follicles with a maximum dose of 150 international unit of FSH. There was a retrospective study of 235th cycle from Germany comparing IVF outcome in patients with and without PCOS, but they noted no difference in clinical pregnancy rate and OHSS rate. My main focus is hyporesponder, because that is a group of women in PCOS that bothers me a lot, because in hyporesponders you start stimulation and you give your gonadotropins, ovaries will not respond at all. It becomes very difficult to really do the counseling of the patient, whether you want to cancel the cycle or you would like to continue the cycle, increase the dose, but how much doses to be increased and what next to offer. Suppose if you do the cycle cancellation, the question comes, to do for me in the next cycle since I have not responded in this cycle. So this is a group which is really a very bigger challenge in IVF, especially in PCO women. So the women who are at hyporesponse or women who have high BMI, obesity is strongly linked to poor ovarian response in PCO patient because of the increased insulin resistance and more hormonal imbalances. Now, the elevated insulin levels can disrupt ovulation and affect egg quality, increasing the risk of poor response to IVF stimulation. There is invariably elevated androgen levels. High levels of male hormone like testosterone can hinder follicle development and reduce the number of mature oocyte retrieved. Previous poor response. If a PCO patient has experienced a poor response to ovarian stimulation in previous cycle, it is likely to occur again. And advanced age women. And high AMH level, as I have already talked about, high AMH, usually you would think that, oh, there is a high number of follicle. But in certain cases, these follicles might be resistant to stimulation from gonadotropins and leading to a poor response despite the high AMH level. This is often seen in women with PCOS, and these high AMH levels are common, but due to unique characteristics of follicle and PCO, they may not respond well to stimulation medication. So I'm just bringing a couple of cases of slow responders. This is the young women with a PCO, and though her AMH was not high, they have the starting stimulation. These were her follicle sizes like 4.5, 5 millimeter. And then again, like this is again the bigger picture of day 3 stimulation, multiple follicle, day 9th of stimulation, multiple follicles just 8 to 9 millimeter with a proper dose of your gonadotropins. Again, on day 11 of stimulation, only 1 to 2 follicle of 15 millimeter, rest all follicles of 10 to 11 millimeter. Day 13 of stimulation, only few follicles in each ovary of 15 to 7 millimeter, rest all are 13 to 14 millimeter. So the point which we wanted to bring here is there's very erratic response of the follicles, because there are some follicles which will outgrow, some follicles which are very small, your estrogen levels will go high, but your total the yield is not going to be that great with PCO. And on the day of trigger, there were only 3 to 4 follicles in each ovary of 18 millimeter. Though after giving the trigger, when we retrieved, we had good 8 to 10 follicles. Then what is the problem is that there is a slow response. And day of starting on the stimulation, this another case, there was enteral follicle count was 20. And day third of stimulation, multiple follicle of 6 to 9 millimeters. Then again, day 6, you see 2 through 3 follicles, 10 to 11 millimeters. Now, you have given 5 to 6 days of gonadotropin. We know that the cycles become very expensive in PCOS because of the prolonged, more number of days you have to give for stimulation, more doses of gonadotropins. So, I mean, it becomes really, really difficult when the response is poor. Then again, on day 9th, just one follicle of 16 millimeter, 2 to 3 follicles of 11 to 10 millimeter restor, 8 to 10 millimeter. So these are the problems you face with PCO stimulation, that there are very less follicles which are really good follicles which you think are going to yield a fertilizable ovum when you do a pickup. So this what ideally you want in an ideal condition, that each ovary should have follicle at least 4 to 5 follicles more than 18 millimeter, 18 to 20 millimeter, and you give a trigger and you get good 7 to 8 follicle. That's an ideal situation, but you are far from ideal in PCOS. And then there is another condition called empty follicle syndrome. Though empty follicle syndrome is still an enigmatic syndrome, which is undeniably annoying as it raises stress and concern for both the treating physician and the patient. So enteral follicle syndrome is a condition in which no oocytes are obtained from mature follicle following ovarian stimulation in an assisted reproductive technology cycle with apparent normal follicular growth and steroidogenesis. So these are the risk factors for empty follicular syndrome, like advanced maternal age, diminished ovarian reserve, high baseline FSH level, low enteral follicle count, high gonadotropin dose during ovarian stimulation, longer duration of stimulation, high body mass index, and PCOS. So empty follicle syndrome, significantly higher dose of gonadotropins and prolonged stimulation was observed in an empty follicle syndrome group. Now let's look at the trigger method, which is to be used in a, which is again a challenge in PCO IVF. Which trigger method to be used? I think there is a unanimously, most of the centers are using GnRH agonist trigger because we want to avoid the OHSS. There some centers were using recombinant HCG, which was established standard for most protocols. But nowadays we have prospective and retrospective studies that we need to use. We are using agonist trigger, and then you have to give a good luteal support. And there is again a concern. There's about using the cabergoline to prevent OHSS from happening. So there is always a debate about when to use cabergoline, whether when you are giving a trigger or at the time of the retrieval, so that it prevents the early rise in VEGF levels and patients experiencing OHSS. We should be using cabergoline. So along with the trigger, you have to consider whether you want to give cabergoline or at the time of retrieval you will be giving trigger. So that's again a challenge in IVF. Then look at the fresh versus frozen embryo transfer in IVF. Once a PCO patient has undergone a successful
I think our connection is.
Yeah, Dr. Archana can't hear you. Some problem with the connection, it seems.
Our network is not there.
I guess the network is not there.
Dr. Pratisha, can you call her and ask her if she could join from somewhere else? Or
Okay, I'll call her.
so meanwhile, we can have some discussion here. So the group which she was talking about, the poor responders, and it has a lot of studies have been done on them, and they found that there could be FSH receptor resistance and LH molecule resistance in these patients, because all the time we thought about PCOS as hyper responders, and then we came across this group of patients who failed to respond. So when we talk about these poor responders, we have to keep this receptor polymorphism also in mind. And to basically antagonize the receptor polymorphism, you have to either, if it is FSH receptor polymorphism, it should ideally respond to higher dose of FSH. And if it is LH receptor polymorphism, in that case addition of LH can benefit these patients, where the patients of PCOS fail to respond to the usual doses. Also, when we talk about the doses, we like Dr. Basaid mentioned, from 75 to 225. Remember that when you are deciding the starting dose in PCOS, keep the BMI also in mind. Don't start at a very low dose for patients who are obese. So obese patients, even if they have a high AMH, they would require a good dose, right? So Dr. Pratishtha, what is the update from Dr. Archana?
I called her and she's trying to join. She maybe कह रही है मैं जल्दी से जल्दी
So
join
how
करने की
many
है.
slides are left for her? Otherwise, we can go to next speaker, and if she couldn't join later, then
Yeah, so that we don't waste time.
don't waste
Exactly.
time, right?
Yeah. So you say, you tell me, I'll call the another next.
Let's start with the next speaker because it's
Yes.
already 5:35. So
Yes,
we'll
and
start.
then in the last, ma'am can sum up
Yeah,
what she
yeah.
wants to actually give the message.
Even if
She
she's
can,
not able to show the slides, if she can sum up whatever
yeah,
Yes,
she
that's
has
right.
covered the
she
Yeah.
most.
can sum
Yeah,
up in the end.
covered.
So
Yeah.
I'll now I call Dr. Bhavani Shekhar, and she has to talk on how to make an OHSS free clinic. So Dr. Bhavani Shekhar, over to you. I'll give a brief introduction of Dr. Bhavani Shekhar.
So Dr. Bhavani Shekhar is a very bright young IVF specialist at Sir Gangaram Hospital, and she has done FNB at Gangaram Hospital, and then she joined as IVF specialist. She has many papers to her credit, and a very research oriented clinician she is. So Dr. Bhavani. Dr. Bhavani, can you start sharing?
Yes, ma'am. Is my screen visible?
Your screen is visible saying Zoom. So you have to start sharing your slide. Yeah.
Meanwhile, Niti, you
Yeah.
often come across patients who are, 80 kgs, 90 kgs, and they want to conceive. The
Yeah.
first thing I tell them is decrease your weight because you're going to land up in missed abortion.
Yeah,
So the
definitely.
dilemma is when they come to you at the age of 32 and they're 90 kgs, how are you going to manage these cases? Maybe we can discuss once,
Yeah.
she's just preparing with her slides.
Ma'am, so when we come across patients who are obese, whether they are PCOS or not PCOS, it also, whether we can wait for the lifestyle management to work for them also depends upon their ovarian reserve. So if they have a very low ovarian reserve, it is better we go ahead with the treatment. Otherwise, we will lose on
Right,
further on reserve. But if they are
right.
PCOS, they have good reserve, we can easily give them 3 to 4 months, and we have to actually give them a very objective idea of weight loss. We can't just tell them go do exercise and diet. You have to send
Yes,
them to a proper dietitian, you have to tell them where to
right,
exercise, how to follow up the exercise, and we have to give them targets which can be measured. So measurable targets
right.
have to be given so that.
Yeah, first of all, we should also tell them about the pros and cons. Now, what are the advantages of decreasing the weight and how it is going to help in their IVF stimulation and all. And then, when they are convinced, they will do it. What I have
Right.
And
found
tell
out
them
is,
objectively what to do rather than just saying, go lose your weights
yeah.
and come back.
That's
You
right.
have to help them out.
Dr. Bhavani, your screen is now visible and you can start with your talk now.
Okay, ma'am. Thank you, Neeti ma'am, for the kind introduction. So the topic I've been given is how to make an OHSS free clinic. So OHSS, ovarian hyperstimulation syndrome, as we all know, is an uncommon but serious complication associated with controlled ovarian stimulation during ART.
Can I request everyone else to please mute themselves? Can you all please mute yourselves?
So the syndrome is characterized by ovarian enlargement with increase in vascular permeability leading to third space fluid loss and prothrombotic effect. Moderate to severe OHSS has been reported to occur in 1 to 5% of IVF cycles. It is a self-limiting condition which needs supportive management but can cause serious morbidity and rarely mortality. So prevention is the key, and the aim should be to make an OHSS-free clinic. So to make an OHSS-free clinic, it is very important to understand the pathophysiology of OHSS. So in response to HCG, the hyperstimulated ovary secretes VEGF along with other vasoactive factors, which causes increase in capillary permeability, leading to third space fluid loss, which results in various manifestations such as ascites, hydrothorax, hypovolemia leading to liver renal impairment, and hemoconcentration leading to thromboembolic phenomena. So, based on the severity, it can be classified as mild, moderate, severe, or critical based on clinical features and certain lab findings. Based on the timing of onset, it is classified as early or late onset. Early onset occurs due to exogenous HCG in the form of a trigger. Late onset occurs in the setting of pregnancy. Early onset occurs usually within 7 days of HCG trigger, whereas late onset occurs usually more than 9 days after HCG trigger. The early onset is less severe compared to late onset and usually resolves with next menses, whereas late onset OHSS can even persist up to the end of first trimester. So, which patients are at risk of OHSS? So, there are certain risk factors which need to be identified at baseline, such as young age, thin build, PCOS, previous history of OHSS, antral follicle count of more than 24, and AMH of more than 3.4 nanogram. Then there are certain risk factors that need to be picked up during ovarian stimulation, such as more than 17 follicles over 10 mm at the time of trigger, elevated estradiol at the time of trigger more than 3500 picogram, or retrieval of more than 15 oocytes. Now, how to prevent OHSS? There are two levels of strategy. One is primary prevention and the other is secondary prevention. Primary prevention means that we identify the baseline risk factors and accordingly individualize the stimulation. Secondary prevention means that we identify those who have already developed an excessive response to stimulation and then we prevent their progression to OHSS. So the various strategies for primary prevention include GnRH antagonist protocol, individualizing gonadotropin dose, lowering of gonadotropin dose, supplementing oral ovulation inducing agents, role of metformin, and aspirin. So we shall be discussing these strategies one by one. GnRH antagonist protocol, as we all know now, there's strong evidence to support its use over agonist in COS protocols in patients with high risk of OHSS. The reasons are that antagonist protocol leads to more physiological follicular selection and recruitment of smaller number of follicles with lesser requirement of gonadotropins and possibility of using an agonist trigger. The other important strategy is to individualize the gonadotropin dose in these patients. So Cochrane 2018 on the basis of 20 RCTs compared individualized gonadotropin dosing based on ovarian reserve test to uniform dosing and found that individualization decreased the incidence of moderate and severe OHSS with no difference in live birth. So it is recommended to individualize the dose based on ovarian reserve test to decrease OHSS in these patients. Third is lowering of dose. So during stimulation, lowering the gonadotropin dose has also been found to reduce the incidence of OHSS, and there is moderate evidence as per the latest ASRM guidelines supporting that. Now coming to the supplementation of oral ovulation inducing agents. So role of clomiphene and letrozole has already been established in poor responders. In patients at risk of OHSS also, there is moderate evidence that supplementing with ovulation induction medications such as clomiphene and letrozole
I think even she's frozen
I don't know what
today.
is wrong today. Bhavani,
I don't know. Dr. Archana is ready actually, but she said she'll do it at the end of the session after the last talk.
Let me call up Bhavani and ask just a minute.
Actually, these are very important topics that we are discussing.
Yes, ovarian hyperstimulation actually is a nightmare.
She's just joining back. She'll just take 1 or 2 minutes. Meanwhile, we can discuss.
Sure.
So, ma'am,
Yeah.
when we were deciding the topics, so the SIG PCOS, our SIG is only dealing with PCOS, and our mentor.
SIG is the Society for Polycystic,
SIG
is the one.
Special interest group.
Interest group.
Special interest group of IFS.
Oh, so it's different from
in IFS, ma'am, Rosa ma'am, in IFS we have special interest groups like SIG, PCOS, SIG, endometriosis, like that.
So this is different from Dr. Durusha's Society of PCOS.
No, yeah, it is different, ma'am. We are from IFS. Yeah, we are from Indian Fertility Society. So SIG PCOS is the convener is Dr. Mala Arora. The mentor is Dr. Mala Arora. I am the convener. And then I have two co-conveners with me, Dr. Parul Garg and Dr. Neelam Bapna. So this is our group, and we keep on having webinars, and even we had a physical conference in Jaipur only related to PCOS.
Very interesting.
Yeah.
I didn't know that.
So so when we were planning this, webinar, Dr. Mala Arora said, "Why you want to discuss about OHSS? It is gone." Manika, where, ma'am? It is never. It is not gone. We still encounter so many patients with PCOS having OHSS, and maybe in IVF we have been able to control. But what about IUIs?
Absolutely.
IUI cycles still. And what about late OHSS? Late OHSS you cannot prevent. Because if you are doing transfers and fresh transfers, so late OHSS can still happen. So it is very important today, all the more important because we have all the things are under our armamentarium, and still if we cannot, make our clinics OHSS free. So in our practice, we have not seen a case of OHSS for a long time now. We are getting referred cases, very sick patients going to ICU, those kind of patients referred from nearby states.
Peripheries.
But we are not getting our own patients. Whatever we have got in last 2-3 years, 1 or 2 patients were late OHSS because it is very difficult.
I agree with Dr. Neeti because I did embryo reduction for quadruplet. She was PCO and was given ovarian oral ovilogen, and she had multiple pregnancy. So what they are saying that OHSS can happen basically in IVF we are controlled, but without IVF it is uncontrolled.
We can do single embryo transfers, so multiple pregnancies can also be controlled in IVF. But IUI goes, uncontrolled. So that is why for all the clinicians, it is very important to identify OHSS and to prevent it as far as possible, and to know when to refer without, worsening them. Yeah, that is
true.
So Bhavani has joined back.
Unable to, what she's saying something.
She's saying unable to unmute. Himanshu, can you help? Himanshu?
Unmute.
I think the IT person should unmute. Yeah, she's okay.
Pratiksha, you please talk to the person who is
Am I audible?
No, actually it is from the center.
Am I
Dr.
audible?
Neeti.
She's okay. Bhavani, you can talk.
You're
okay,
audible
okay,
now.
ma'am.
So we all will mute now, and Bhavani can
Yeah.
speak.
So I was talking about supplementing oral ovulation inducing agents. So role of clomiphene, citrate and letrozole is also coming up in these patients at high risk of OHSS, and there is moderate evidence that supplementing with ovulation inducing medications causes significant reduction in amount of gonadotropins required and incidence of OHSS without a significant difference in live birth rates in these patients. Now coming to the role of metformin. it is hypothesized that metformin affects ovarian response by reducing the number of non-periovulatory follicles and thereby reducing estradiol secretion. Studies are now have addressed whether metformin during ovarian stimulation for IVF in patients with PCOS can reduce OHSS in this high risk group. So there is moderate evidence that metformin reduces incidence of OHSS in PCOS patients at high risk of OHSS in the setting of GnRH agonist protocol, but the same effect has not been seen in antagonist stimulation protocol. So in agonist protocol, it is recommended, but not in antagonist protocol. Role of aspirin. Aspirin has been considered for risk reduction of OHSS based on the fact that increased platelet activation because of VEGF levels may lead to release of certain substances such as histamine, serotonin, platelet-derived growth factor, which potentiate the physiological cascade of OHSS. And aspirin has been shown to decrease the incidence of OHSS, but the level of evidence is presently weak. Now coming to the secondary prevention strategies. So first talking about GnRH agonist trigger. As we all know that GnRH agonist trigger leads to a short duration of LH surge lasting for only 24 hours, resulting in early luteolysis, whereas HCG trigger occupies LH receptors for a longer period of time of up to 7 days, leading to late luteolysis and increased VEGF production. So therefore, GnRH agonist trigger is strongly recommended to trigger oocyte maturation in these patients who are at high risk of OHSS. And however, there is strong evidence that live birth rates are lower in fresh cycles after GnRH agonist trigger. Therefore, it is recommended to add adequate intensive luteal support when using GnRH agonist trigger and planning a fresh transfer. Whether a low dose of HCG trigger can be used in these patients, there is insufficient evidence to recommend this. Now coming to the freeze-all strategy. So OHSS free clinic by segmentation of IVF cycle was first talked about by Paul Devroy in 2011, which included segmentation by 3 strategies. First, antagonist protocol, freezing all embryos, and frozen embryo transfer. So there is strong evidence that avoiding a fresh transfer and freezing all embryos significantly reduces the risk of moderate and severe OHSS. Now coming to the role of dopamine agonists. Dopamine agonists such as cabergoline or bromocriptine prevent phosphorylation of VEGF receptor and reduce release of vasoactive angiogenic agents, thus preventing OHSS. So a daily administration of 0.5 milligram of cabergoline or 2.5 milligram of bromocriptine for 8 days, starting from day of trigger, has been found to reduce the incidence of moderate to severe OHSS, and there is strong evidence supporting its use. Now coming to posting. Posting is a process where the gonadotropin therapy is discontinued for a variable period prior to trigger till safe estradiol levels and adequate follicle sizes are attained. Optimal length has not been determined, but posting for more than 4 days has been found to decrease pregnancy rates. Posting has primarily been described for agonist cycles, and according to Cochrane 2017, analysis of only 2 RCTs showed low quality evidence that posting reduced moderate or severe OHSS rates. But the evidence is weak supporting its use. Now coming to volume expanders, also known as colloids. So volume expanders such as albumin or HES post-oocyte retrieval have been hypothesized to play a role in OHSS prevention. Albumin, by increasing plasma oncotic pressure, counteracts the permeability of angiotensin, and it also binds to vasoactive substances such as renin-angiotensin factors related to renin-angiotensin system and VEGF. So albumin, being a blood-derived product, may lead to allergic reactions, anaphylaxis, and transmission of viral diseases. HES, however, is a volume expander that has now gained attention as an alternative to albumin in reducing incidence of OHSS due to its low cost, and being a non-biological substance, it avoids the potential concern of viral transmission. So what does evidence say about volume expanders? At present, there is weak evidence that the use of volume expanders such as albumin or HES reduces moderate to severe OHSS. Coming to the role of letrozole in the luteal phase, elevated serum estradiol observed in the setting of a robust response to ovarian stimulation has been strongly associated with increased risk of OHSS. So high serum estradiol increases VEGF via estrogen receptor modulation. Because of this relationship between estradiol and VEGF, it has been proposed that letrozole administration post-retrieval will decrease serum estradiol levels and thus may reduce the incidence of OHSS. However, currently there is only weak evidence supporting its use for OHSS prevention. Coming to the use of GnRH antagonist in luteal phase, administration of GnRH antagonist in the luteal phase for 3 to 5 days post-retrieval has been proposed as a potential intervention to accelerate luteolysis, thus reducing ovarian VEGF secretion and preventing OHSS. However, currently there is insufficient evidence to support its use for this purpose. Now coming to calcium infusion, increased calcium is postulated to inhibit cyclic AMP stimulated renin release, thus decreasing subsequent VEGF production. However, currently the evidence is very limited with only one RCT which has shown promise for prevention of OHSS. There are certain additional strategies also which are being studied, such as administration of mifepristone, myoinositol, chiroinositol, glucocorticoids. However, currently the evidence is insufficient. Now summarizing the preventive strategies, the primary preventive strategies, antagonist protocol and individualizing gonadotropin dose have a strong evidence and are strongly recommended. Lowering gonadotropin dose, supplementing ovulation-inducing agents, and metformin show moderate evidence and are recommended. However, metformin recommended only for agonist, not antagonist protocol. Aspirin, as of now, has weak evidence, therefore not recommended. Agonist trigger, freezol, dopamine agonist, strongly recommended, whereas coasting, volume expanders, luteal, letrozole, and antagonist, weak evidence, not recommended. Thank you.
Very nice talk, Bhavani. Wonderfully, you elaborated on all the preventive strategies. One thing just I wanted to mention here to all the audience here is that even agonist trigger is not absolutely, risk free. Just remember that there are already papers they are published where they have given agonist trigger, GnRH antagonist cycle, agonist trigger, and they have still landed up with OHSS. So please don't be in this, of course we have to give agonist trigger in GnRH antagonist cycle, but still OHSS can happen, remember that. And the crux would be to stimulate, do a mild stimulation. As Dr. Bhavani said, maybe using oral drugs, less dose of gonadotropin. So mild stimulation will always be important. Don't think that you can take out 50 eggs and there will be no problem because we have agonist trigger in a GnRH antagonist protocol. That is very important. Thank you, Bhavani.
Thank you, ma'am.
I think, Neeti, you have summarized the whole thing well. Good. Let's go ahead with the third speaker, Pratishtha.
Our third speaker is Dr. Ashita Punjabi Hakku, and she is a consultant in Neelkant Infertility and IVF Center, Faridabad, and she has been associated with various studies and research work. Dr. Ashita Punjabi will be speaking on the current update on the management of OHSS. So, Dr. Ashita.
Good evening, everyone. I'm sharing my slides.
Yeah.
Yes, it is seen. Ashita, go ahead.
Yes, ma'am.
Just make it full screen, Dr. Ashita, if you can.
Yes, ma'am. Yes, ma'am. Just one second.
So you are at Neelkant Fertility, Faridabad, right?
Faridabad Center, yes, ma'am.
Okay.
Good evening, everyone. I would like to extend my gratitude to IFS MP chapter along with SIGS PCOS for giving me the opportunity to give a talk today on this platform. And today my topic is current update on management of OHSS. Uh, OHSS, as we know, is the gravest complication of controlled ovarian stimulation. It is something we are always fearful of. We all want that our clinic should be OHSS free. Most of my talk will be from ASRM 2023 and the British Fertility Society 2024 guidelines. And therefore, I think most of the things are going to coincide with the previous speakers also. But I will try to make it short, not try to reiterate the things again. As we know, there are various classification for OHSS. It can be classified by NAVOT 1992 classification into mild, moderate, severe, and critical. Mild OHSS somehow we encounter quite frequently, but moderate, severe, critical, we all take the prevention so that we might not land up in these conditions. We know the risk identification and counseling is the most important thing in our practice. As soon as the patient comes to our clinic, we and especially when the patient is a hyper responder, we must see that yes, she is a high risk patient for OHSS, and our counseling should be meticulous. At it is going to be a roadmap to a safer, more informed treatment journey. So, what are the risk factors which can lead to ovarian hyperstimulation syndrome?
Dr.
According,
Ashita,
yes,
sorry
ma'am.
to interrupt, but can you
Yes,
just leave the prevention part and go to the management only because we have talked about that?
ma'am. There are few points from British Fertility Society. Can I
Okay,
just
yeah,
tell
sure,
them?
sure,
Yeah,
sure,
yeah, yeah.
sure.
Okay. So regarding the protocol, as we all know, the GnRH antagonist protocol, it is preferred over the long GnRH agonist protocol. The same has been said by the British Fertility Society also. And when we compare the GnRH antagonist protocol with the PPOS, that is progesterone primed ovarian stimulation protocol, there is level 2 evidence that there is similar risk of OHSS with PPOS as compared to the GnRH antagonist protocol. So for PCOS patient, the PPOS protocol is equally good to go. Regarding the gonadotropin dosing, according to ASRM, they say that there is good evidence or moderate evidence that lowering the starting dose of the gonadotropin or supplementing with the oral ovulation inducing agent, they decrease the risk of OHSS. But when we talk about the British Fertility Society policies, they say a reduced gonadotropin dose could be considered in predicted high responders who are receiving the GnRH agonist protocol to decrease the risk of OHSS, but a conventional gonadotropin dose can be considered for safety and efficacy when you are using a GnRH antagonist protocol. So there should be a balance between efficacy and safety. According to this article by Magnuson et al., the cumulative delivery rate per aspiration, it increases up to 20 oocyte. We also know the paper by Sunkara et al., where the magic number is 15. But when we talk about the OHSS, according to this paper, the risk of severe OHSS, it increases after the follicular count of 15. So post 15 to 18 oocytes, the risk of OHSS is more. So our stimulation should be in such a way that we may not land up with OHSS while having a good live birth rate also. Now, regarding coasting, as already discussed, it is to withholding the gonadotropins until the estradiol level and follicle sizes are appropriate for the trigger for the final maturation of oocytes. The rationale for the same is to reduce the circulating gonadotropin levels, leading to the apoptosis of granulosa cell in small and medium-sized follicles, while larger follicles that are gonadotropin independent, they continue to develop. So, according to British Fertility Society guidelines, it can be considered in patients who are at risk of OHSS based on ovarian response again in GnRH agonist protocols. It should not be considered for prevention of OHSS in GnRH antagonist protocol. Trigger, we all know that in hyperresponder, we give the GnRH agonist trigger. Yeah, according to British Fertility Society, many a times there is a notion that we can give a lower dose of HCG and it might prevent the OHSS. I have also seen many colleagues doing the same also. They begin with very low dose of the gonadotropin and they also give the trigger HCG, low dose HCG. But according to this British Fertility Society, whether you are using low dose, you are using high dose, it carries a similar risk of OHS even in general IVF population. And it doesn't depend on whether you are using recombinant or the urinary HCG. Regarding the intensive luteal phase, so after the GnRH agonist trigger, as per the American protocol, they use in intensive luteal phase, they use a low dose HCG. Uh, sorry, in European protocol, they use low dose HCG along with the GnRH agonist trigger in luteal phase. But again, this also has been seen to increase the risk of OHSS, and it is level 1 evidence. Regarding dopamine agonist, I would just like to add that many studies they say that we have to start the cabergoline either on the day of HCG or on the day of starting of the progesterone or on the day of oocyte retrieval. But as it is believed that it's a post-ovulatory phenomena, the LH receptor will be gained by the granulosa cell only post-ovulatory. But this has been denied by in the papers of Kamath et al. And this is a paper, it says if we start the cabergoline therapy early, that is when the size of the leading follicle is only 15 mm, then it can cause the decrease in the OHSS rate. So these studies advocate for the early administration of cabergoline for prophylaxis against OHSS. Letrozole again has conflicting results. Regarding the GnRH antagonist, again the data is limited. We have small or very low quality studies. In established cases of OHSS, according to RCOG 2016, there is insufficient evidence to support the use of GnRH antagonist. Low dose aspirin, when we give the low dose aspirin, it only blocks the pathway which converts the arachidonic acid to thromboxane A2, which is basically responsible for the thrombotic complication. If it is given in doses higher than 325 mg, then it will cause the reduction in PGI2 synthesis also. So giving in low dose will lead to increase in PGI2 to thromboxane A2 ratio and therefore have its vasodilatory effect and anti-VEGF effect. So British Fertility Society, it says that aspirin may be associated with lower risk of OHSS in women undergoing IVF using GnRH agonist protocol, but again the evidence is inconsistent and it should not be used to prevent OHSS during COS stimulation in intact protocols. Metformin again. So basically, the studies which say that the use of metformin is associated with decreased risk of OHSS, they were mostly done in GnRH agonist cycle. The systematic review again in 2015, it says that it is associated with significantly lower risk in PCOS population of OHSS, but most of the studies were of GnRH agonist cycle. This nicely done RCTs, which showed the use of metformin to reduce OHSS in GnRH and tag cycle. And this was the first adequately powered RCT to show the impact. According to this study, it doesn't support the prescribing of metformin as an adjunct to GnRH and tag treatment cycle. So according to British Fertility Society, metformin administration reduces the risk of OHSS in women with PCOS who are undergoing GnRH agonist cycle, but not in women who are undergoing GnRH and tag cycles. Freeze all, I think it is the best policy. Elective cryopreservation of all the embryos and the subsequent transfer in the next non-stimulated cycle. But again, there are case reports where even after freeze cycles, the cases of OHSS have been seen. So only, as ma'am has already said, to go with the GnRH agonist trigger and doing elective cryopreservation doesn't guarantee that the patient will be OHSS free. It should be the norm that you have to call the patient in which you suspect she is at high risk of OHSS. Don't call her on day 1, 2 of the cycle. Call her after 2 to 3 days for the follow-up. Calcium infusion already stated by the ma'am. So in calcium infusion, there are associated risks that it can cause arrhythmias, tissue necrosis, and hypotension and bradycardia. So there was this one paper where they saw that if we are giving IV calcium infusion, and this study showed that there are good results in preventing the OHSL. Why not to go ahead with the oral calcium? Because the basic phenomena is that the calcium, it will inhibit the CAMP mediated renin secretion from the juxtaglomerular cells of afferent arterioles. So why not to go with the oral calcium? But again, in their study, they saw that it was not adequate for preventing the OHSS in high-risk patient. So still, the higher studies, meticulously done studies are needed on this topic also. Additional treatment as well. Okay, regarding the management, firstly, outpatient management. The patient who you think is at risk of developing the OHSS, you should provide a 24-hour contact number to the patient. She should be called up for follow-up after 2 to 3 days. It is very imperative to have face-to-face clinical examination. Just patient is calling you saying, I'm having vomitings, I'm having pain abdomen, and we are prescribing them Pentop or Emised. This should not be the protocol. Patient has to be called up to the clinic for face-to-face clinical examination. She has to be told regarding the fluid intake and output monitoring and relevant investigation, CBC, LFT, RFTs, the coagulation profile that should be ordered and followed if required. So who are the patients who will require the admission? So patients who are having severe abdominal pain, nausea, vomiting, severe ascites, profound oliguria, anuria, tachypnea, dyspnea, patient having hypotension, electrolyte disturbance, abnormal LFTs. Also, those patients who are unable to attend for regular outpatient follow-up, they are the indication for admission. So how to monitor these patients? We have to monitor their vital signs. Their input-output charting should be done. Saturation should be monitored. Their weight, constant abdominal girth. In biochemical monitoring, hematocrit. It is very important to assess the degree of intravascular volume depletion, serum creatinine levels, electrolytes level, to check for the leukocytosis, liver enzymes, and ultrasound for the fluid to see any significant ascites for ovarian size. If required, arterial blood gas analysis, ECG, chest X-ray. Regarding pain for symptomatic relief, adequate analgesia should be given. One should avoid NSAID as they can have the renal consequences. Antiemetic should be prescribed. Fluid replacement. Crystalloids are useful for initial correction of dehydration in women who are unable to maintain adequate oral intake. But it should not be like that because we know it's a state where under the influence of VEGF, the capillaries are leaky. So we should not be so over enthusiastically loading the patient with the crystalloids so that she will have all the fluid in the third space and it will only worsen our condition. So meticulous input output charting with the crystalloids to replete the dehydration, that is important. Regarding the volume expander albumin. So we know that albumin, it has got plasma oncotic properties, about 75% of the plasma oncotic pressure, and administration of 50 gram of human albumin will draw more than 800 ml of extracellular fluid in the circulation within 15 minutes. It has got binding and transport properties, so it can cause inactivation of VEGF by binding to it. It also has got osmotic function that it will maintain the intravascular volume in the event of capillary leakage, thus preventing the sequelae of hypovolemia, ascites, and hemoconcentration. So this is the Cochrane in 2016. in which regarding albumin, there was evidence of beneficial effect of IV albumin on OHSS, but we have to take this with pinch of salt that the studies which were included, they had high heterogeneity. They were labeled as very low quality evidence. According to this, if the rate of moderate or severe OHSS with no treatment is 12%, it was only 9%. The range was 16 to 12% with the use of IV albumin. And what they saw that there was evidence of detrimental effect on pregnancy rate. So for those who were undergoing the subsequent fresh embryo transfer, also adverse reactions which are associated with albumin is that there can be allergic reaction, severe anaphylaxis, and there can be transmission of viral or unidentified disease. Now, hydroxyethyl starch. Hydroxyethyl starch, as it's a non-biological substance, its use avoids any potential concern about viral transmission that may be present with albumin. But again, the beneficial effect, it was based on only two small studies having total of only 272 women. Again, we have to be very particular about what we are picking up from this Cochrane. So, ASRM guidelines have been discussed. According to British Fertility Society, the use of albumin, it is not associated with a reduced incidence of OHSS. It should not be considered for the prevention of OHSS. Regarding hydroxyethyl starch, it is already banned in UK since 2013. According to them, in critical patients, in sepsis patient, HES has been seen to interfere with the coagulation profile, and in long term, even after 7, 8, 9 months, it can have its renal repercussions. Anticoagulation, as we know that severe OHSS is a prothrombotic state due to hemoconcentration and vascular endothelial dysfunction. So the patient with severe or critical OHSS, they should be started on anticoagulation. Regarding the time or duration till which we have to give it, it has to be decided individually because there is no particular guideline regarding it or recommendation regarding it. Antibiotics, if needed. Diuretics, they should be limited only to the pulmonary edema, as OHSS leads to loss in the third space. Already the volume is depleted. This is only going to aggravate the already deteriorated situation. Yes, the cases where the oligouria is not responding to good volume replacement there as a part of diuretic challenge, we can add the diuretics, and also in cases of pulmonary edema. Paracentesis. So in my lifetime, I have seen only one OHSS case during my FNB, and in that, inadvertently, the patient was given HCG trigger, um, even though it was planned for elective cryopreservation only. But because of that trigger, she had severe OHSS, and I think we had to drain her. We had to do the paracentesis twice or thrice for her. So that was the only case till whole my life, which severe OHSS, which I have seen, and I largely attribute it to the HCG trigger. Severe abdominal distension and abdominal pain, which is secondary to ascites, shortness of breath and respiratory compromise secondary to ascites, and increased intra-abdominal pressure. Oligouria despite adequate volume replacement secondary to increased abdominal pressure causing reduced renal perfusion. These are the indication of paracentesis. Surgical management is restricted only if there is ruptured hemorrhagic ovarian cyst, if there is ovarian torsion, or there is ectopic pregnancy. In the last, I just got this paper by Kamath sir, management of severe ovarian hyperstimulation syndrome with thawed plasma. In this paper, they say the case was of azoospermia, IVF, along with PISA was done. The patient was having 14 to 15 follicles. Trigger was HCG. Patient was underwent a fresh embryo transfer on day 2, and I think 2 embryos were transferred on day 2. So patient developed severe ovarian hyperstimulation syndrome. Her albumin on serial test, it got reduced to 1.7. They required paracentesis 6 times. So finally, they talked with their medical oncologist, who in case of cancer, they see recurrent ascites. So they were advised regarding the thawed plasma. So that patient was transfused with 4 units of thawed plasma in 48 hours, and it resulted in dramatic improvement in the patient. And 26-day post-retrieval, the patient was discharged, and after this procedure, she didn't require any further paracentesis. So the take-home points, it is imperative to identify the patient who are at risk of OHSS and counsel them accordingly. We have to take proactive steps to prevent the OHSS. Agonist trigger with elective cryopreservation should be our choice. Thank you.
Thank you, Ashita.
Thank you, ma'am.
Quite well talk about your OHSS free clinic. Very elaborate. I think we'll wait and hear about Archana, and then we can take questions at the end. Pratishta? Because already we are running short of time. You're mute,
Yeah,
Pratishta.
we have a panel discussion left, ma'am. So I
I
think
know.
a question and answers we can take afterwards, and we'll start
Okay.
with the panel discussion right away, so that you know, we
You
get
don't want Dr.
ample.
Archana to summarize? She wanted to summarize. Dr.
Archana,
Archana
ma'am.
she messaged me. Archana, would you like to summarize? I think Pratishta, go ahead then. Go ahead because you're already very late. Neeti, we
Yeah.
are going ahead with the panel then. Archana is not there.
Yeah,
Otherwise, she
I
would
think
have
she had
some.
some slides left. No, she didn't. She wanted to present those slides also.
Yes, she mentioned. She
She's
messaged me.
she's showing online, but I guess she's
Okay,
not.
then we go ahead with our panel discussion. All right.
All right.
Okay.
So can I take
Thank,
your leave, Neeti
thank you
and
so much.
Pratishta?
Thank you so
Thank
much,
you
Yeah,
so
ma'am.
much, ma'am,
lovely.
for
It
joining.
was
It
a
was
pleasure
Lovely,
to have you
lovely.
around, ma'am.
yeah.
Thank you so much. Oh, Archana is here. Archana, I'm taking your leave and going. Bye.
Thank you, ma'am. Thank you.
Bye.
Thank you,
Bye-bye.
ma'am.
Bye.
So shall we start with panel discussion now, Neeti, ma'am?
Yeah, you can start sharing your slide. So Ashita, very nice presentation. So
Thank you, ma'am.
Dr. Priya had a lot of good words to say about you, and I'm sure whatever she said seems to be correct because
Thank you
you
so
are an
much, ma'am.
excellent
Thank
speaker.
you.
Very nice slides also. Only one
Thank you,
thing I
ma'am.
wanted to comment here is that
Yes,
when
ma'am.
you talk about diuretics
Yes,
in
ma'am.
this thing, we know that in OHSS diuretics are not recommended.
जल्दी कर
This
लो.
is very important that you should not give diuretics because there is already intravascular dehydration.
Relation,
So
yes,
if you
ma'am.
give diuretics, the BP will fall very dramatically
Yes, ma'am.
because there is already intravascular dehydration. So if you are not able to get urine output after giving crystalloids and colloids, the next step could be doing a paracentesis. And if
Yes,
after
ma'am.
doing a paracentesis also you're not able to, then dopamine infusion can also be tried in renal
Yes,
doses.
ma'am.
So
Yes, ma'am.
dopamine infusion is a better choice because we have
Mm-hmm.
managed a lot of patients earlier in ICU, referred patients.
Yes, ma'am.
So dopamine infusion is the thing which usually our nephrologists they suggest instead of giving Lasix. Lasix is definitely the furosemide is the last thing which you should think of giving in patients of OHSS.
Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Ashita.
Thank you, ma'am.
Dr. Pratishtha, you can start. I was waiting for you to start, so that's why I was just making.
Yeah, I'm just trying to share the screen, ma'am.
Yeah.
Are you able to see, ma'am?
Yeah, we can see you very well, but you can if you can make it full screen, it would be good.
Full screen. It is not actually. It goes some problem with the laptop, so I'm not able to. If it can be done.
Okay, no problem. No problem. You go ahead.
Okay, so we'll start with the panel discussion. For panel, we have the moderators, Dr. Parul Garg. Dr. Parul Garg is presently working as the head of the Department of Reproductive Medicine at Artemis Hospital, Gurugram. And she's an executive member of Indian Fertility Society, and she's also a co-convener with SIG PCOS IFS 24 to 26. The second panelist is Dr. Neelam Bapna. I have not received her slides, but Niti ma'am, if you can introduce her, you might be knowing. All I know is that she.
Dr. Neelam Bapna is a very dear friend of mine now. We are working together in SIG PCOS, and she's a very senior IVF specialist from Jaipur. Dr. Neelam, can you unmute yourself?
Yeah, good evening, everyone.
Good
Yeah, I'm
evening,
from
Dr.
Jaipur.
Neelam. So nice to have you around.
Yeah.
Parul, can you unmute yourself now? Himanshu,
Do
please.
it.
You can also.
Yeah.
Okay.
Hello, hi.
Hello, hi, Parul.
Yeah. So can we
So
start a
welcome
panel discussion?
both the moderators. We have also have a very good team of panelists, vibrant. They are just ready to answer the questions they were asked. The first one is Dr. Shalini Chavla Khanna, and she is the Joint Secretary, Delhi Gynae Forum South, and also the executive member of Indian Fertility Society since 2020. We have Dr. Shweta Gupta. She is the director IVF Max Super Speciality Hospital, Delhi and Noida, and also she is the treasurer of. She was the treasurer of joint treasurer of IFS in 2022. Then we have Dr. Tejashri Shrotri. She is the director of MedFame Women's Clinic, Hoskas, and she is the senior consultant Obs Gynae Apollo Cradle Royal New Delhi, and also a consultant IVF unit Sir Gangaram Hospital, New Delhi. Then we have Dr. Anju Verma. She's from Gwalior and is the director of Dr. Verma Hospital and Fertility Center. And she's also the vice president of Gwalior Obs and Gynae Society and vice chairperson of MP chapter ISAR, and also the organizing secretary of MP ISAR Conclave 2023. Then we have Dr. Kalyani Shrimali, and she is a senior consultant reproductive medicine at Nova IVF Indore, and she has been taken a keen interest in recurrent implantation failure cases as well as in poor responders and poor ovarian reserve patients. She has also received many awards, and she has currently she is the member of Foxy Endocrinology Committee and executive member of MP ISAR. Lastly, we have Dr. Varuni Shukla. She is a senior. She is was an associate professor with Subharti Medical College, and now she is working as a gynecologist and director of Vaibhav Memorial Hospital, Gwalior. She has also done ART fellowship and fellowship in minimal access surgeries. Dr. Shushmita Mukherjee is a very senior gynecologist and IVF specialist from Indore, and she is the managing director of Dr. Shushmita Mukherjee Fertility and Laparoscopy Center. She is trained herself in advanced laparoscopy, IVF, and high-risk pregnancies, and she is also an executive committee member of IFS MP chapter. We welcome you all, and handing over this thing to Parul Garg and Dr. Neelam Bapna for panel discussion. Thank you.
Thank you, Dr. Nikita, for the kind introduction. So I will be moderating the panel discussion on IVF in PCOS along with Dr. Neela. And as you know, IVF in PCOS is the third line management after oral ovulations and gonadotropins do not work. But there are so much challenges in IVF in PCOS, and we have amazing talks today with by our speakers on these problems. So let's see whether we can do justice to this panel discussion. Now, case one is a 34-year-old woman with PCOS, that is a BMI is 28, AMH is 8.5, AFC is 24, has a history of anovulation and poor response to multiple ovulation induction attempts, including clomiphene, letrozole, low-dose gonadotropins. So she is now undergoing IVF. So in her first cycle, she was stimulated with an antagonist protocol using 150 IU of urinary FSH, but follicular growth remains slow with a follicular size 9 to 12 mm even after 7 days of stimulation. Then in subsequent cycles, she was stimulated with an antagonist protocol with 2 to 25 IU urinary FSH, but by day 6, her estradiol levels were lower than expected and only 4 follicles were growing. Now, what could be the possible reason for poor ovarian response in this patient despite her high AMH and AFC? Dr. Shweta, ma'am.
Yeah, hi. Thanks, Parul, for
Yeah.
inviting all of us. I think this is a very interesting situation and very, I think, even though we feel it is a PCO is a high responder, but this practical situation where we actually end up with very, and we are scared not to increase the dose, so we end up getting a very less number of follicles. And this is because of the hormonal imbalance. There is a excessive estrogen, and that sometimes because of the negative feedback can affect the pituitary ovarian hypothalamo-pituitary ovarian axis and can suppress actually the FSH. So we are scared, we don't use, but actually there is less of FSH, there is a suppression of FSH, and in the end we get very few follicles. So I think in both the scenarios, the first cycle and the second cycle also, there was less number of follicles which actually were getting matured. So if I have to do it, probably I'll increase. It's an antagonist cycle. I will increase the dose of the FSH, whatever we were using, recommended FSH, or maybe Humog. So maybe to the 300.
Fine, fine. Dr. Tejashri, you want to add anything?
Sometimes this could be also considered as a FSH receptor polymorphism,
Yes.
or maybe a LH receptor polymorphism, because it is a response that lesser response than expected. And here either ways, either we can increase it to 300, or I would even at middle of the cycle, since we have started with a certain dose, we could add a little bit of LH. I personally would prefer adding HMG, maybe 75 units to the cycle.
Okay, fine. Dr. Anju, you want to add anything? Is Dr. Anju is there?
Yeah, I think she's
Yes, yes.
mute.
Hello. Yes.
Yeah. You want to
Can
add
you hear
anything?
me? Yes.
Yes, yes.
Actually, yes. Same thing here. I also want to use HMG in such type of patients, and many a times because of the hyperendogenous. We must diagnose hyperendogenous before stimulation and hyperinsulinemia.
Yeah.
Otherwise, we should add HMG in such type of the patients, because many a times high AMH indicates poor type of the follicles. Because of the degeneration of the follicles, AMH got so much high, and there is very poor type of the oocytes and FSH not responsive. So it is better to use HMG. I preferably use HMG.
Okay, fine. So
Actually,
our panelists have already
because of very high AMH, the follicles are not responsive to FSH. That is the problem. So, in this case, prior cycles also with the oral ovidigents and low dose gonadotropin, the patient was not responding. So, prior lifestyle management and efforts to lower the AMH could have been done, and then one can plan the cycle, or a mid-cycle LH addition would have helped.
Okay. So there are two main culprits, as you already told, is the high insulin and high androgen levels, and they are responsible for metabolic abnormalities and the reproductive failure. So we have seen a high insulin levels and a high insulin resistance in the PCOS patient, because this insulin amplifies the LH-driven androgen production, leading to high intra-ovarian androgen, therefore suppress the FSH-mediated granulosa cell function. Therefore, we required a higher FSH dose is required, as well as a longer duration of stimulation. Obesity, as we all know, is requiring a high dose of medication, and fewer follicles are formed at a given dose, and it impairs the ovarian responsiveness to the gonadotropin and
We
longer
can't.
stimulation duration. And also the genetic variants, as already Dr. Tejashri had told, it's a FSH receptor as well as a LH receptor polymorphism is there in these PCOS patients. So now how will you proceed in this particular cycle, Dr. Varuni? Dr. Varuni is here. Sure. Hello.
She's muted, I think, Parul.
So,
Yeah.
Dr. Sushmita, you can answer this question.
Yeah, along with recombinant FSH, we can add recombinant LH also, although it makes the cycle bit costlier, but we can get a good yield of oocytes in that case.
So you will start
also
with
in case
the
of
new
PCOS,
cycle, or you will add the LH in this cycle, or increase the dose of FSH in this cycle.
mid-cycle LH can be added.
And okay. And Dr. Shweta, you want to add something?
I think, see, we can discuss with the patient. She already, I don't know how many days have already gone past, and so there will be, I think, four follicles were developing. So
7 to
there
8
will
days, yeah.
7 to 8 days. So we can add, increase the dose. We can go to the step up and expect them little more follicles to get ready and catch up. So there will be a longer duration of stimulation. The other option is that we stop it here, and then maybe next cycle with a higher dose we start maybe
Yes,
with the 300.
And you will prefer a urinary FSH or recombinant?
See, if the cost is a problem, then Humoc will be better. Because as you know, the recombinant LH will be very expensive, and Pargoveris or something, like that is very expensive. Really, it will increase the cost. So simple Humoc can be helpful in this case.
And Dr. Tejashwari, want to add anything?
No, I think one more thing that I want to add is that if we are going ahead with the next cycle and canceling this cycle, I would really like to look at the baseline LH, what was there if we have done it in the previous cycle. If she's a LH hypersecretor, I would prefer that since we are canceling it, we could give her a little pre-treatment with OC pills, bring down the LH, and then start stimulation. That really helps sometimes to make the ovaries sensitive to the recombinant FSH.
So in this, we can cancel the cycle, or we can add LH or increase the dose of FSH, or switching to intrauterine insemination, IUI also, if the tubal obstruction is not present, or duo SIM, because the patient is a poor responder in the 2 cycles, so we can offer embryo pooling. And switching from IVF to IVM as a salvage strategy. This is one article we found. In this, whatever the follicles we are seeing not responding, we can go for IVM. And there is one article which show that is transvaginal ovarian drilling followed by controlled ovarian stimulation from the next day onward. It can improve the ovarian response. So not all women with PCOS are high or normal responders to ovarian stimulation. Although not a high proportion, some women with the PCOS fulfill the positron group, that is group 1 and 2, and there are limited data available regarding the pregnancy outcomes of women with PCOS classified as a poor responders. So now this patient belongs to group 1, that is a patient is less than 35 years and a good AFC and AMH, but it's a poor responder. So it is divided into 2, group A less than 4 oocytes are retrieved, and group B more than 4. So this comes into unexpected poor ovarian response. And this is a study which show that positron group 1A displayed as you have already getting a low number of oocytes, so there are low rates of implantation and a live birth rate, but there is no significant difference observed in the rates of clinical pregnancy and a live birth between the positron group 1B and a non-positron group. So in next cycle, how would you modify the ovarian stimulation protocol in this patient for better ovarian follicle response? As Dr. Kalyani, she is here? Dr. Anju?
I think we must evaluate for hyperandrogenism and hyperinsulinemia, adding of metformin, and then we can add instead of FSH, we can start HMG, or we can give the 1 to 2 month OC pills or antagonist protocol along with HMG. I think this is by this protocol, patient usually respond in PCOS.
Okay. And what will the dose you will start?
According to weight and age, usual HMG dose is 225.
Okay. Doctor, you are doctor?
Anju.
Andrew. Dr. Kalyani, want to add anything?
She is not here.
She is not
Dr.
here.
Varuni? Okay, Dr. Varuni.
Yeah, ma'am, I would like to suppress the prior cycle with the OC pills. Then I would like to start with the, because you already used the 220 dose of FSH. Now
Yeah.
I will try to increase a little amount of dose to 275. And then I will, from 5th day onwards, I will switch on to HMG.
Okay. Okay. Dr. Sushmita, you want to add anything?
Yeah, there is another way. We can start with FSH and HMG combination. If you want to keep it a bit economical from the very start, and monitor and get better response, and start with 300 dose.
Yeah. So this we have, okay, this we have already discussed the causes of low follicle to oocyte indices. They can be low gonadotropin starting dose, as this is a patient, and they can be genetic factors, asynchronous follicle development, technical issues involving trigger for final oocyte maturation or oocyte pickup. So this patient is a group 1, having good reserve, good quality. So we can have this possible reason. They can be, we can start with as patients already have a antagonist protocol, we can have the start with a recombinant FSH instead of urinary FSH, and also add LH from the day 1 of the stimulation. And this success is minimum of 5 mature oocytes for 1 euploid embryo. So regarding the use of recombinant FSH, this is a study which shows that use of recombinant formulation, although it's very costly, is associated with a significantly higher number of erythrocytes than the urinary formulations. And these findings seem to be related to the higher biopotency of the recombinant formulations. And usually we start with a higher starting dose of gonadotropins, that is a 300 IU in the next cycle, and we will add HMG from the first day of the cycle. So this is a study which shows that if we increase the recombinant FSH, that is a main only significant predictor of the number of oocyte retrieved in the subsequent IVF cycles. So we increase 50 units of initial recombinant FSH dose will leads to 1 more oocytes. And adding the recombinant supplement, obviously, as we know, it improves the, this is basically, this is basically low suboptimal response. So if we add a recombinant FSH either in mid-cycle or from the day 1, it will definitely improve the response. So synchronizing the follicular cohort. So what you prefer, Dr. Shweta?
Yeah, Parul, we can either give it estrogens, previous, or like somebody suggested OCP also previous cycle, so that we have a better cohort developing.
Yeah.
Yeah, and of course in this we have already decided a higher dose, 300.
Higher dose, yeah.
But
So
there are
if
many
we,
studies, but there are many
yeah,
studies which says that
so we have what?
yeah, hello.
Yeah.
So there are many studies which says that adding OCP's pre-treatment in antagonist cycle may reduce the live
Yield
birth
is
rate,
less.
but
Yeah.
may not be that
Yeah.
good. So it's better to do pre-treatment with estrogen or progesterone.
Yeah.
There are many studies. Yeah.
This
And
already told by
prior to starting with our stimulation, sometimes we can give 3 days of antagonist and then start with our stimulation. That it also helps us in getting a good cohort.
Yeah, the role of oral antagonist can also come in near future, although there are not much studies, but yes, pre-treatment oral antagonist may also come for these kind of patients.
Here,
Yeah.
I would just like to add one point. Since we are talking about PCOS here, and if we are considering a pre-treatment with estradiol, it is very important to confirm that she's ovulated in that cycle. Otherwise, endlessly she will be taking the estradiol for days together, but she will not get her menses. So it's very important that we confirm that she's ovulated before we start only the estradiol thing, or we can add meprate for 5 days and then start estradiol till she starts her menses.
Yeah. Usually we start the estradiol in previous cycle from 21st day of the cycle after confirmation of
Confirming
ovulation.
ovulation.
Yeah. So this is a best practice in positive group 1 I will be talking. So in this, if we have to increase the recombinant FSH dose, that will be if there is no variant, then it is 50 to 75. And if it is FSH variant, then we will increase by 75 to 150. I mean, minimal daily dose should be 300. And if we are considering adding a recombinant LH as in this patient, that where there is a history of follicular stagnation, it will be a 2:1 ratio of recombinant FSH and our recombinant LH from the first stimulation day. And obviously, we have already discussed consider the antagonist regime, agonist protocol, agonist trigger, and elective embryo freezing. In cases, it's high FC and AMH, and consider the single blastocyst embryo transfer. Now coming, would you consider switching to progesterone primed ovarian stimulation? Or anyone is using this type of stimulation PCOS patient?
Yes.
Okay.
Yes. Especially in donor cycle or
In donor cycle, yeah.
yeah.
Okay. That is that we know it's a patient friendly and
Yeah.
we can use in
Cost
donor, but
effective.
in a patient, just to improve the egg quality or embryo quality.
Evidence says that it is equally effective as
Yeah.
antagonist. So
Again,
is
it's a
another
very
option.
newer protocol, Parul. So
Yeah.
I think we need more evidence to
More
say
evidence,
to
right,
make it
right.
as a standard
Yeah,
way of
we are
stimulation.
still on antagonist protocol. We haven't
Yeah.
moved to PPOS regimen in PPOS patient. And there are studies that show that using this progesterone prime ovarian stimulation, they have improved quantity, quality, and development potential of oocyte and embryo. And this is a mechanism behind is that administering the progesterone during the follicular phase can slow the LH pulse frequency, block estrogen-induced LH surge, and promote the oocyte health and the cytoplasmic maturation, therefore lead to better embryo development. But this is a systemic analysis which shows there is no evidence to support the PPOS which can reduce the risk of OHSS, increase oocyte maturation, or improve the pregnancy outcome in women with PCOS undergoing IVF. So this is preferable, especially as it is a patient friendly and we are doing in a donor cycle. So now comes the use of adjuvants. So what do you prefer? Metformin, minoxidil, coenzyme Q10, melatonin, and growth hormone. Dr. Shweta ma'am, please बताइए. What do you prefer?
Well, we do use, I use metformin,
Yeah.
sometimes CoQ10 also,
Okay.
and it helps in insulin resistance overcoming.
Yeah.
I think, especially when we have time and we are going into lifestyle, and then it's a good, it will be good to add these to correct the, the hormonal and the insulin sensitization. It will help, especially if the patient is obese.
Yes,
If the
yes, yes.
BMI is more, then this will be a good to add.
Good to
Uh,
know. Yeah.
but alone as metformin as a ovulation induction may not be very good. But yes, supporting with the letrose may be a good idea, especially in obese.
Okay. Dr. Tejashri, what you want? I mean, what you prefer using
So,
adjuvant in
out
PCOS
of these,
patient?
only metformin is something that I would like to add because evidence is not very supportive of rest of the things like myoinositol, CoQ, and melatonin. Growth hormone, in this particular case, some people might use it, but personally, I have no experience of using growth hormone.
Okay. Dr. Anju?
Same here. I usually use metformin But in few cases, we can also combination of metformin and myoinositol. Some
Okay.
drugs are in combination. If patient
Combination.
is affordable, because myoinositol is little costly drug and
Mhm.
metformin is cheaper. And metformin is giving better result than myoinositol in my
Yes.
experience.
Yes, yes. And Dr. Varuni, what do you prefer?
So as the all others are saying, I would like to go with metformin and
Metformin
letrozole. Yeah,
and
letrozole also. Yeah.
letrozole also. Okay. And Dr. Sushmita?
Yeah, metformin, if we think about evidence, it is more effective if it is an agonist cycle. In
Yeah.
antagonist
In
cycle,
preventing the OHSS, yeah.
yes,
Hmm.
evidence-based medicine, if we practice, then it doesn't have a very good role in antagonist cycle. But in our routine practice, definitely we are using metformin and sometimes the combination along with myoinositol, and to increase the sensitivity of insulin indirectly helps. Yeah.
Okay, so let's see what the evidence say. So metformin is a good insulin sensitizer. It decreases the insulin levels, hence increases also decreases the glucose level. Therefore, improves the insulin sensitivity in the body. And it is recommended by the latest guideline, that is 2023 PCOS. Even in the patients of every patient of PCOS, even in the if the BMI is less than 25, as it has a good beneficial effects on the metabolic parameters. Inositol is also another insulin sensitizer, but according to new guideline, new evidence base that is there, that shows that this is evidence support the use of inositol in the management of PCOS is limited and inconclusive, as we don't know the exact dose and exact side effects. Then melatonin, some studies have shown because there is a metabolic dysfunction that is a major contributing factor in the PCOS, it hinders this process by improving the effects of metabolic functions. And coenzyme Q10 also, this is a systemic review and meta-analysis, which also shows improvement in PCOS patients by improving the insulin resistance, increase the sex hormone levels, that increase FSH, reduce testosterone levels, and improve the blood lipids. Now, growth hormone, as we know, is obviously not a evidence base, but this is RCT which shows that it improve the rates of implantation and a clinical pregnancy, but it's not significantly. So next case can be taken by Dr. Neelam.
Yeah. So this is already we have learned a lot about OHSS in the previous two talks. So this is a case of 29-year-old woman with PCOS. She's undergoing ovarian stimulation for IVF using an NTAG protocol with 150 IU of RFSH. Her BMI is 27, AMH is 12.3, which is very high. AFC is quite high. And there's no history of OHSS in the previous cycle because this is her first IVF attempt. And on day 8, you see that 22 follicles of more than 12 mm have been growing, and the estradiol levels on day 8 itself was more than 5,000 picogram per ml. And she started having symptoms of mild abdominal discomfort and bloating. Next slide, please, Parul.
Yeah.
So the question is, what is the best strategy for final oocyte maturation in this high-risk patient?
Definitely agonist trigger. There is no question about it.
Yeah.
There is no if and but about this. Yes. Yes, this is the best strategy to use is agonist and freeze all. Next, please. So this is the ESHRE guideline, which says that triggering final oocyte maturation with GnRH, agonist, and freezing all suitable embryos is recommended if antagonist protocol is used. Next, please. So the advantages are that it is this agonist trigger is a potential to induce a rapid and reversible luteolysis, and therefore it decreases the risk of OHSS. But the disadvantage is that there is concomitant severe luteal phase defect resulting from a short period of induced LH and FSHP. And also it inhibits the secretion of VEGF from the corpus luteum. And therefore, there is a significant reduction in the incidence of OHSS or early OHSS with the use of agonist trigger. So this was a study where they compared the high responder patient with both triggers, dual trigger and the agonist trigger, and they said that there was no statistically significant difference among the collected oocyte number of mature oocyte, fertilized embryos, good quality embryos. But yes, the risk of OHSS would be more with the dual trigger.
Dual.
Now, what should fresh embryo transfer should be considered, or the freeze-all strategy is preferable? I think all panelists would be
freeze-all.
Same opinion, yeah. So a freeze-all strategy is recommended to fully eliminate the risk of late onset OHSS. Next, please. So what preventive measures can be taken during stimulation to reduce the risk of OHSS in this patient? Yes.
Low dose.
Yeah.
Start with a very low dose and gradually increase.
Yeah.
And in between, do ultrasound and monitor the follicles and also the E2 level.
Yes.
In between.
So I think in this case, she was only day 8. So probably I'll reduce the dose. The follicles still appear not yet ready. So with reduction of the dose, monitoring very closely, more frequently, calling every day or every other day patient. And because at least the follicle should be ready. What I saw is she was about only day 8. So taking it to the right size, because otherwise we'll not get even the mature eggs, and then giving agonist trigger and definitely freeze all, as we all agreed.
We can also
And
provide
also cap
posting.
hold it. Huh?
Posting we can also give 1 to 2 days.
Yeah, I think costing can be given, or at least reduce the dose to
Reduce the dose,
75.
yes.
Yeah, back to 75. And then agonist, along with the trigger, you can also add Capgoli.
Yeah. So okay. Next slide, please. So these are various preventive measures which can be done to prevent the risk of OHSS. Like all said, lower starting dose of GI gonadotropins, avoid HCG, posting, metformin, use of mild stimulation protocol like adding of letrozole along with gonadotropin in next cycles. We do not know whether PCOS protocol would lead to decreased incidence of OHSS, and early cabergoline and aspirin. So this has already been explained in detail by our previous speakers. So ASRM guidelines have strong evidence about the antagonist protocol, trigger agonist, freeze-all technique, and the use of cabergoline on the day of HCG trigger for several days. And yes, adequate support in the luteal phase. The moderate evidence is that gonadotropin dosing should be individualized based on the ovarian reserve testing, and consider lower gonadotropin dose, or you can add clomiphene or letrozole in the ovulation induction. The strategies which are not recommended for OHSS prevention, or those who have very weak evidence, are posting alone. You can consider posting only with cabergoline or freeze only strategy, or you can add luteal GnRH antagonist, but there is no significant reduction in the OHSS rates. Aspirin, although can be used, but it is not effective for OHSS prevention. Albumin, hydroxyethyl starch, mannitol, they are also not of much benefit. And mifepristone, myoinositol, all those have no benefit. And metformin in GnRH antagonist cycle is not significantly effective. So if you are using a metformin in antagonist cycle, that will not help in reducing the OHSS. It's better to use letrozole for OHS prevention in these patients.
Ma'am, letrozole specifically is very effective in reducing the OHSS post ET. If we
Yeah.
give for 5 BD, it's
And
very
very
effective.
cheap also.
Very
I mean,
economical.
cost effective.
Yeah, very economical also.
And one more thing, that when you do the retrieval, you have to retrieve all, even small follicles also, to reduce the risk of OHSS, because you cannot just retrieve the larger ones and leave the smaller ones, because you have
Will
to,
decrease the estradiol level. Truly.
yes, so you have to retrieve each and every follicle and also the smaller ones. So this is again a preventive aspect. So now she develops moderate OHSS post-trigger. So what are the best management strategies?
So a moderate OHSS can be managed on outpatient basis.
Yes.
And however, we need to explain to the patient not only verbally, but in a written form, or regarding all the signs and symptoms when she should report to the hospital. Like if she's not passing urine or breathlessness, or maybe increased girth of her abdomen. And in that case, it would be helpful if she can do a abdominal girth measurement and a weight measurement daily. We should call her the next day, at least at 2 days later, at least, if she can't come immediately on the next day. But the best would be to call her the next day to get an ultrasound done to see the amount of ascites and the ovarian volume, which would help us diagnose the increase in the size that we did a day prior. But not only that, we would also send the blood work in the form of hematocrit, LFT, KFT, to see whether it's worsening. Also, she should be asked to drink to thirst, to not overload her with fluid.
And also not to exert too much, because there is a risk of torsion of the ovaries, may happen, or even slight trauma can lead to rupture of the follicles and the catastrophe. Yes. Next slide, please. So this is the classification of the severity of OHSS, where a moderate OHSS is moderate abdominal pain associated with nausea or vomiting, ultrasound evidence of ascites, and the size of the ovaries are 8 to 12 centimeter cube. The severe OHSS, when there is clinical ascites, including hydrothorax, oliguria, hematocrit more than 45, hyponatremia, hyposmolality, hyperkalemia, and hypoproteinemia. And critical is when there is dense ascites and the hematocrit is more than 0.5. Next, please. So outpatient management, as already told by Dr. Tejashree, we have to take care that